All right. Good morning, everyone. We're going to go ahead and get started. Welcome to all of you that are here in person and to everyone who has joined us online. I'm Mindy Hamilton. I am the current president of the professional staff, and I'm honored to be here today. So welcome to our Grand Rounds event. Whether, again, you're joining us virtually or in person, thank you for taking time to be here. Today, we have a special presentation of the Howard A. Mermelstein Award, Memorial Award, and followed with a lecture. So it's going to be a really special morning. A couple of housekeeping items before we get underway. If you'd like to ask our speaker a question, please type it in the Q&A, and we've got some folks monitoring that. In addition, if you want to engage with the presenter, ask the webinar host to unmute or give you access to turn on your camera, and we'll try and help you through that. And for anyone who's attending in person, we have a couple of travel mics. So when time comes for questions, we'll bring those around so that you can actually ask your question that way. So today we gather together to celebrate the memory of an outstanding physician, Dr. Howard Mermelstein. Dr. Mermelstein was a dedicated pediatrician, trusted friend, and compassionate caregiver who devoted his life to caring for Pittsburgh's children and their families. I think we have a couple slides to come forward here. Let me see if I can just do it. Give us a minute, technical difficulties. There we go. Okay. Dr. Mermelstein began his career at Children's as a pediatric resident in 1949. Over the course of his career, he became known as a respected mentor and a published clinical investigator. Dr. Mermelstein also provided valued leadership to our medical community by serving as past president for both the Allegheny County Medical Society and the hospital's medical staff from 1989 to 1990. I actually now would like to turn the program over to Bob Mermelstein, Dr. Mermelstein's son, to provide some remarks on behalf of the family.
Thank you, Dr. Hamilton. It's hard to believe that it's been 32 years since our husband, father, brother, and beloved friend passed away. I suspect that some of you have never heard of Howard Mermelstein before today. I'd argue that we wouldn't all be sitting here today if it weren't for the pioneering efforts of people like Howard Mermelstein, Gene Weiner, and Paul Gaffney, and others. If one were to design a Mount Rushmore to represent Children's Hospital, surely one of the images would be the face of Dr. Howard Mermelstein. Dad was larger than life, standing at 6'4½". He was beloved to his community almost from the time he was asked by Dr. McCluskey to be one of his residents in the early 50s. He had an energy, grace, and class that were infectious. In practice, he always had a way of making patients feel like he had all the time in the world for them, yet did it with total efficiency. My brother-in-law, Paul Dubner, was lucky enough to practice with him, along with the late Bernie Michaels and Dick Paul, in what was previously known as the University Community for 7 years before his untimely death in 1991 after a courageous battle with lung cancer. He worked full-time, intermittently using oxygen until 3 weeks before his death. He had a deep love for this institution, on whose staff he served as president, as Mindy indicated, as well as on numerous committees. But his love extended well beyond Children's Hospital and the patients of his practice. He was deeply committed to the well-being of the practice of medicine in general, as evidenced by his service to Allegheny County Medical Society, of which he served as president actually in 1979. He was deeply committed to the Pittsburgh Jewish community, in particular the Jewish Family and Children's Service, now called Jewish Family Community Service, of which he served as president, and for which there's a similar award presentation every year. He was deeply committed to the city of Pittsburgh, living in Shadyside and Squirrel Hill and adoring his Steelers. But most of all, was his unconditional love for his family. While this lectureship and annual award presentation began in 1994, the actual endowment wasn't fully funded until 2007. My mother, Bev Mermelstein, and we three kids, my sister Margie Dubner, my sister Jan Shaw, and I, as well as our aunt Eleanor Mermelstein, my father's late sister, decided that his name should live on forever, so we created this endowment and award presentation. Special thanks to Carol Ashby, Amy Gelthizer, and all the staff of the Children's Hospital Foundation, providing the nuts and bolts to get this done. I do want to mention that it's been 32 long years since a Mermelstein has roamed the halls of CHP as professional staff, though my brother-in-law Paul has certainly been an important part of the medical community since the 1980s. My daughter Bryn will be joining the nursing staff and will be a pediatric oncology nurse on 9B starting in 2024, and we're very excited about that. I hope this provides a little background for the development of the criteria for the selection of honorees for this award. The criteria for eligibility have been well outlined, so I don't need to reiterate them here. The awardee is chosen by closed ballot distributed by either regular or electronic mail to the entire medical community, medical staff, and reviewed by a small representative subcommittee of the medical staff and a member of the Mermelstein family. Dr. Jeffrey Kurland is this year's awardee. As a transplant surgeon, he's compassionate towards his patients and their families, and a great mentor to his colleagues. One of the testimonials for his nomination had this to say: Jeff never misses the opportunity to share jokes with everyone around him, which gives a sense that he's deeply rooted in humility and has a sense of humor that makes sometimes very scary or tough situations feel lighter. He's also a two-time cancer survivor and has written a book about his patient experience. Even during cancer treatment, he remained deeply involved in patient care remotely and was always available. The Mermelstein family is very happy to honor Jeff Kurland with this award. I would like to ask Dr. Mindy Hamilton to present the award to Dr. Kurland.
Thank you, Mr. Mermelstein, for sharing some memories of your father with us. And I am very honored to present this award to Dr. Jeff Kurland. A couple more things that came with his nomination: that he has been here at Children's for 35 years. And his career certainly reflects the values that Dr. Mermelstein was so well known for. This includes a very large commitment to teaching, betterment of the profession, very beloved by his patients. I'm not sure I know too many other physicians that are as beloved by their patients, and all of us actually, as Dr. Kurland. Integrity that is very well recognized by his peers, and active in the community. As Bob Mermelstein mentioned, Dr. Kurland has run the lung transplant program here for many decades, most often without help. I think people have kind of come and gone, but he's stayed a consistent and solid, and it is an incredibly important program to him. He's here every weekend, even when he's not on call. And I've certainly personally, as many people in this room have seen that. He's a great educator. He's dedicated his career to imparting his vast knowledge of pediatric pulmonology onto decades of residents, fellows, and faculty. I'm going to throw myself in there. He's trained a countless number of pulmonologists across the world, and he has great pride in this, as he should. As Mr. Mermelstein mentioned, he is a two-time cancer survivor and has written a book, which, if you haven't read, is amazing. He never misses the opportunity to share jokes, and some of them are good and some of them are not, but it's something you can sort of count on in all of our times of busyness and being overwhelmed or being sad at work. It puts a smile on your face. So I am honored to present this award to Dr. Jeff Kurland. I guess that's pretty good. Please, a few words.
For those of you who don't recognize me in this, I really am Jeff Kurland, okay? I have some prepared remarks, and I'll try to be brief. I will be brief. First of all, this award and its inspiration, Dr. Howard Mermelstein, are daunting to say the least. To be considered worthy of this award is an unexpected blessing, leaving me honored and humbled. But I also must acknowledge those many people who helped me become the physician I am now, and those who continue to point me towards becoming the physician I aspire to be. I had wonderful mentors early on in my college career, working as a kid in a research lab over the summers, and as a medical student, pediatric resident, and then fellow at Stanford University. In the late 1960s through the late 1970s, I learned a lot by observing the importance of collaborative research, by witnessing the high standard of clinical excellence I saw there daily in the faculty, and probably just as important, because Stanford, after all, is close to San Francisco, by hearing a lot of great music at places like the Fillmore, Avalon Ballroom, and Winterland. I was lucky enough to be taught medicine, while at the same time getting exposed to live appearances by the likes of Chuck Berry, Jimi Hendrix, Jim Morrison, Grace Slick, Janis Joplin, Eric Clapton, and many, many, many others. And I must admit that I don't remember all of this, because as they say, those who remember the 60s didn't fully participate. I moved to Pittsburgh in 1988 after having been a pediatric pulmonologist at the University of California, Davis, which actually is in Sacramento, believe it or not. For most of the time I was there, I was the only pediatric lung specialist, was on call 24/7 without a fellow or resident, made rounds 7 days a week, learned flexible bronchoscopy, and for a very thankfully short time, actually was the acting director of their small PICU, and I was never trained in the PICU. My time in Sacramento helped me become the clinician that I am now, mainly because I had to learn to make difficult decisions based on limited data, with often limited understanding on my part. My colleagues, patients, families, and nurses were all supportive, even though during those many times when my knowledge was insufficient to save my patients. Moving to Pittsburgh was the most important and best move I've ever made in my life. This place, this children's hospital, allowed and encouraged me to become the best version of myself. My patients and their families continue to inspire and teach me almost daily. My colleagues in other services have supported me, despite my penchant for telling bad jokes. But I should especially give thanks to my division, pediatric pulmonology, whose physicians, nurses, and staff are dedicated to helping children breathe better. I get to work every day with some of the smartest and best coworkers that anyone could wish for. Every day I am here, I have a chance to learn something new. Every day is a new challenge. Every day is another chance to be a better doc. And so I accept this award with humility, knowing that it's not for me alone. I share this award with all of you, as we are all aspiring to be the best medical team at the best children's hospital. And for those of you who, like me, must face so often the difficult decisions that we must make, we should all remember the words of Siddhartha Mukherjee, the physician, scientist, and author. In his book, The Laws of Medicine, he reminds us that human decision-making, and particularly decision-making in the face of uncertain, inaccurate, and imperfect information, remains absolutely vital to the life of medicine. Here's to that life of medicine. I thank you again.
Wonderful. Thank you. No joke. I think he's already off the podium. I'm sure he could come up with one if we asked. So I'm going to move forward with the second part of our morning, which is our lecture, the annual Howard Mermelstein lecture. So I'm very pleased to introduce Dr. Nasuh Malas as our speaker this morning. Dr. Malas graduated from the University of Wisconsin, where he received both his doctorate of medicine and a master's in public health. He completed a 5-year triple board training with board certification in pediatrics, general psychiatry, and child psychiatry here at the University of Pittsburgh. Dr. Malas served as the division director and service chief for child and adolescent psychiatry at the University of Michigan, as well as the chair of the Mental Health Quality and Safety Committee at C.S. Mott Children's Hospital. Currently, he's the primary investigator for the Children's Hospital Zero Suicide Initiative, a partnership with Cardinal Health, the Children's Hospital Association, and 15 other peer institutions. He serves as a physician co-lead on the Michigan Medicine Workplace Violence Prevention Lead Team, and Dr. Malas is completing his first year as a member of the State of Michigan's Governor's Commission on School Mental Health and Safety. Nationally, Dr. Malas is the chair of the Child Psychiatry Committee for the American Association for Emergency Psychiatry, as well as a member of the Planning Committee for the National Updates in Behavioral Emergencies Conference and the annual conference for the AAEP. He's a member of the Physically Ill Child Committee, Emergency Psychiatry Committee, and Clinical Essentials Committee with the American Academy of Child and Adolescent Psychiatry, where he was also honored as a Distinguished Fellow. He's also served on the Psychiatry Residency in Training Examination Executive Board from 2012 to 2014, and has rejoined again from 2018 to 2021. As you can hear from all of this, Dr. Malas has been incredibly influential in the field of emergency psychiatry, consultation psychiatry, and hospital-based psychiatry, publishing national guidelines on pediatric boarding, as well as the care of pediatric delirium, pediatric somatic symptom disorders, and pediatric aggression. He has a fantastic resume, and I suspect that the lecture that we're all going to hear is going to be just as fantastic. So please join me in welcoming Dr. Malas.
Hi, thank you. It's so lovely to be back in Pittsburgh. I was driving through the Fort Pitt Tunnel, and I really missed that view. And it's just so amazing to be here with you all. Thank you to the Mermelstein family. Congratulations. I don't know if Jeff is still here. Oh, there he is. Congratulations. Just thank you all for hosting me and inviting me to speak. So I am going to talk about a topic that I think is fairly germane to many of you. How many folks have seen a patient that's expressed agitation? All right. How many of you have experienced agitation yourself? Okay. All right. So it's a very, very common issue. However, in pediatric medicine, we oftentimes don't conceptualize agitation, aggression, behavioral dysregulation like we do in other areas of medicine. So if there's one thing you get from the talk today, it's to really conceptualize these behaviors as a sense of disequilibrium. When you see a fever, when you see an aberration in heart rate or blood pressure, it's not about just treating that issue, but it's getting at the etiologies that are driving that issue and really using our interprofessional expertise to deliver care that really attends to the full extent of the etiologies driving that condition, and then iteratively assessing what is going on as that vital sign changes. So we'll see as we talk, this conceptualization has really helped us at the University of Michigan develop some really unique and innovative strategies. No disclosures, despite being in practice now for 9 years. I can't share that, but maybe at a future talk I can share some disclosures. So objectives. So we have a very ambitious talk today. Goal is to really focus on some practical strategies to address agitation and aggression across the spectrum, and to specifically focus on some evidence-based guidelines we've developed nationally, as well as talk about systems-based issues that we've been able to employ to prevent and mitigate progression of behavioral dysregulation. So as a psychiatrist and a pediatrician, words are really important to me. And so really want to frame our discussion along these definitions. And the reason I like these definitions, although there's not a unified, universally accepted definition for agitation and aggression, is I think these definitions really help guide the rest of the conversation. So I see agitation as a state of increased cognitive, emotional, and motoric activity associated with heightened autonomic response. So the reason this is important is to see the behavior as tied to changes in emotion. So there is some type of emotional valence put to the event, put to the context of the event that is driving or influencing the behavior. So understanding that emotion helps you intervene upstream. You know, you are angry, you are sad, you are scared, helps you not just attend to the behavior, but understand the emotion tied to it. But even upstream from that, and our folks that are really into cognitive behavioral therapy will love this, there are the thoughts, the cognitions, right? So I had a bad experience in the hospital because I, was poked and prodded and I had a really negative experience. And so now I'm anticipating bad things happening that are driving my emotions, that are driving my behaviors. So we can anticipate these things and think about them critically, but there are also physical signs that we can see, physical changes in motor movement and vital signs that can help us understand some of the antecedents before the behavior presents. These are related to stressors. So there are factors that can heighten that risk of agitation, as well as intrinsic patient-related factors. So there are static risks that patients may have, whether it's a history of aggression, cognitive limitations, pain, sleep deprivation, hunger, a variety of patient-related factors that we can identify early and address early to mitigate that progression to what we see as aggression. And aggression really is that extension of agitation, whereas agitation progresses, as those factors progress, you then see external signs of that agitation presented as verbal or physical behaviors that then create an unsafe environment. So really thinking about this along a spectrum. When I started at the University of Michigan back in 2014, it was all about what meds can we use to get these young people to settle down, to calm. And we had to do a tremendous frame shift. And it was very hard because everybody wanted to go to the solution to design a series of meds to deliver, and really understand actually we need to see this as an entire spectrum. What do we do when patients are calm to keep them calm? And how can we understand as they progress through this progression? Also understanding the pathophysiology, and this is, this could be a talk in and of itself, but understanding there are factors related to psychological, cognitive, neurophysiology that can predispose you to agitation and aggression. So this is some graphics from a paper back in 2008 that really highlights the pathophysiology, but you can see there are domains of potential deficit. So individuals may have emotional or behavioral dysregulation sensitivities. They may have a trauma history that then gets re-triggered by their experience in the hospital or in the outpatient environment. They may have cognitive limitations that really inhibit their impulse control, their judgment, their ability to attend. And also there are several derangements in neurotransmitter function. The ones that have been probably most described are dysregulation in serotonin, but enhanced dopamine effects are particularly significant. And we see a lot of effects in the frontal cortex. We see a lot of effects in the limbic system and how we perceive different events and what limbic outputs can occur. And any deficits in these areas can also predispose you to agitation and aggression. And it's also the larger systems issues. What is the care team's experience? How is the care team affecting the individual? How is the family and relationships outside the hospital potentially exacerbating or potentially protective? The medications we deliver, are they disinhibiting? Are there drug-drug interactions? So it's a very, very complex picture. And as I stated earlier, the way that we've really tried to conceptualize this as a vital sign. So as we kind of think about all those signs that demonstrate that there is a disequilibrium in our body's ability to maintain our body temperature, blood pressure, etc., that allows our body to function. Agitation and aggression is a sign of CNS disequilibrium, where when we see that, that should prompt us to think about what are the etiologies really impacting that presentation. So a little bit about our story at the University of Michigan. I started there in 2014. And this is a story that's very common nationally, even to this day. But, we had very limited mental health consultation. And at that point, there was just me on a consult psychiatry service. Saw about 20 consults a month, very limited activity. Nobody knew how to access us. Everybody was complaining, why isn't psychiatry at the bedside? So, a lot of challenges in terms of accessing mental health care. No unified training, no standardized approaches, just highly, highly heterogeneous. And when you think about developing a pathway or a guideline, it's to take a very common issue that is highly, highly heterogeneous. And we know that agitation can present in all kinds of individuals at all times for a variety of different reasons. And it requires that there's evidence. So we do have growing evidence as to what works and what doesn't work. And so this was primed for development of a pathway to standardize and really create a more structured approach to identifying risk early and then addressing it in a methodical way with interprofessional delivery of care. The other thing that we'll talk about is how developing a pathway really mitigates bias and stigma in the delivery of this care, because when you have a lot of variability, you are reacting to your own personal biases, and that potentially can be have a negative outcome for patients and families. We think about screening and prevention did not exist at many places, and a lot of trauma for our staff. Workplace violence, particularly we've seen it in the headlines for nursing, but it affects everybody, is really difficult. What happens is sometimes we could start demonizing or projecting our fears and our distress onto patients. And so what we want to do is support our nurses, support our staff by creating a framework that really helps them be empowered to support patients and families rather than be in situations that can generate trauma and injury. This is our hospital over at the University of Michigan. We have 245 beds, see about 30,000 ED visits a year, 12,000 outpatient surgical cases, about 7,000 discharges a year. We have an embedded 16-bed inpatient psychiatric hospital. So our psych hospital's in the children's hospital, which is nice because we can see kids who have a variety of medical complexities on our psych unit. Our units also partition where 3 of the beds are for highly acute behaviorally dysregulated youth. So that's an advantage. And actually, we're doing another study right now where access to inpatient beds, direct access, actually significantly affects boarding times, and it significantly affects our decision around safety for patients in the ER setting. So having that access is actually critical to the work we do. And then we also have a separate psych ER. Our psych ER sees adults and kids, and unfortunately, those populations are cohorted. We're working on that at the University of Michigan. But having that psych ER is another dynamic that allows us to buffer our crisis services. So when we got to Michigan, knew we needed to develop something. This was a tremendous issue, very, very dependent just on our security professionals, and we needed a more interprofessional approach. So we brought together a work group, and a couple things that I learned early on is really that interprofessional perspective is critical. It's really, really important to make sure everybody who's touched by the issue is engaged as a stakeholder, and making sure you have individuals with lived experience on your group. So we had parents with kids with autism, with kids with aggression on our group, informing the language, informing the perception of what we were doing. So to give you an example, we wanted to identify outside of patient rooms who was at risk for agitation and aggression. As you can imagine, that's highly stigmatizing if you're bringing your kid in and there's something on your door that says your kid has a behavioral issue. So we vetted a variety of things, and the symbol that came up that people felt was not as stigmatizing and be helpful was a stoplight. So we created a stoplight tool with the families. We actually vetted the language around the tool and called it a behavioral support tool, which was the language that the families felt was really non-stigmatizing. And now we use that as an identifier outside the patient room. So if you're, a surgeon, if you're a nurse, if you're a social worker, before going in that room, look at the behavioral plan, identify what kind of issues may be triggering. Is it sensory stimulation? Is it certain language? Talk to the bedside nurse, make sure you know what's going on before you walk into that room and potentially walk into a challenging situation. So this is the state back in 2014. People were very, very frustrated by all this heterogeneity and lack of access to service. And so one of the first things we did as we developed this working group was we did a national survey. So we wanted to get a sense from hospitalists and consult psychiatrists, what are they doing? What's happening across the country? So this was really foundational for us. And what it told us is really there wasn't much going on. A lot of folks found that this was a really important issue. About 70% rated it as an 8 on a 10-point Likert scale. Saw it very commonly, but many sites did not have screening. Those that did screen were screening for suicide. And that's not really getting at the issue of agitation and aggression. Those who were engaging families were doing it in a general kind of patient family-centered way, but preemptively asking families about what are the triggers or potential factors that can contribute to agitation, asking them proactively about what are comfort strategies, posting that in the room, referencing it regularly, being able to iteratively update that tool was not happening anywhere that we could find. 60% of physicians at these sites did not have any training in agitation or aggression. 52% were not aware of training or agitation in non-physician staff. So, we think about our nurses being those frontline care providers. Half of the sites not even knowing if they're receiving any training. Could you imagine going into a cardiorespiratory code and not being sure if the other people have any training at all in what they're doing and trying to coordinate a complex cardiorespiratory resuscitation? And in these behavioral events, although they're very different, there are some similarities given, the risk to the patient, risk to the care team. And that's pretty scary to see that, a lot of sites did not have that, as well as a lack of guidelines. Interestingly, we asked folks when they are in these situations, what do they think is the primary factor driving those presentations? And it was split between primary mental illness and medical or physical illness. But what's interesting is when we asked the psychiatrist, what do you think is driving the presentation? They said primary medical illness. When we asked the hospitalist what's driving it, they said mental illness. So the value of this for us, this is what we gleaned, is that you need that interprofessional team approach, right? If you just have security, they're only going to look at it through a security lens. If you have psychiatry, they're going to overvalue the medical and maybe dismiss some psychiatric issues. If you just have the hospitalist, they may overvalue the psychiatric piece that they don't know as much about and maybe dismiss some of the medical piece. So having that multidisciplinary team allows you to have that rich conversation about the diversity of factors contributing. We also did a needs assessment internally to really understand what our system needs were. We ended up surveying 492 individuals. This was a convenient sample. About 44% responded. And it was a 26-question survey that I'm happy to share if people are interested afterwards. But what we found, not surprisingly, universal lack of comfort with increased access, feeling more comfortable managing these issues when there's increased access and use of available resources. Not surprising at all, but discomfort in actually implementing these services. So told us that we need to make sure that there's a framework where the universal training and the universal strategies that we're going to offer have to be buttressed by a hierarchy of providing support for higher risk issues. So you can't do this if you have no mental health support. You can't do this if you don't have any security support. It's just not going to be feasible. And also just a lack of training inherently in implementing these factors. And years of experience had no effect on the responses to comfort. As expected, learning preference was really hands-on. So doing an online module once a year is not going to cut it in terms of training for this population. You want to do case-based, small group, more intensive hands-on learning. And that actually influenced our choice of training at the University of Michigan. We also looked at different disciplines. The theme was largely that this is a very time-consuming effort, right? And there's no standardization at this point. So people are just kind of moving through whatever they think is necessary. And then a lot of concerns from our nurses and social workers, which I think we can all appreciate, regarding escalating verbal and physical aggression. And this was back in 2014. It's only gotten worse since. We also asked a case-based question. We presented a case of an individual adolescent in DKA who was presenting with delirium and asked about what would you do first? And luckily, the first intervention was non-pharmacologic behavioral intervention. But then after that was engaging security. And then after that was thinking about the underlying physical disease. So the concern here is in somebody who has DKA, who has delirium, that the third thing you would think about is managing the medical condition or thinking about the physical disease was a bit concerning for us. And that security came above that in terms of most common response. Was interesting for us to find. In terms of common non-pharmacologic interventions, people felt comfortable providing emotional validation, less comfortable providing distraction and active coping skills. So something we could employ. Few participants, luckily, jumped to restraint as an intervention. Obviously, there's a place for using restraint, but really trying to mitigate that until you've exhausted interventions that you need and making sure that it really is required to ensure safety. And then we had some responses about pharmacologic intervention. But the other interesting thing about this is the folks that were really recommending or having it high on their list of recommended interventions were actually the non-prescribers, indicating that medications needed to be used. So this really highlighted to us that for the bedside nurses, we need to partner with them to help them understand with the physicians, how are we using these meds? What are their risks? And are there things we could be doing differently? So fast forward, this has been our journey in the last 9 years. Started off in 2015 with some interventions. We developed a family behavioral response plan. So any family that's struggling, there's a standardized form in the EMR that we can walk through, that we can iteratively update to help partner with the family. So previously, we had a behavioral contract. The problem with that language is that families felt that they were not being heard and that they felt that they had to sign off on something that they didn't necessarily agree with. So we took a approach of really trying to partner and understand with the family and use the standardized tool to do that. We also really started this work group. The following year, we developed standardized assessments. We developed a behavioral support plan for youth that could be iteratively updated. And then we piloted a screening that I'll show you later so we could identify risk early and employ interventions early. We then in 2017 started de-escalation training for all of our staff, clinical and non-clinical staff. We use a model called WELL. We'll talk about that, but there's a variety of different models you can use, CPI, others. But the idea is to really kind of develop foundational skills in de-escalation so we can mitigate the progression of agitation and aggression. As you heard earlier, we have a mental health quality and safety committee, so we needed oversight. So it's not just about delivering the interventions, but making sure there's fidelity, making sure there's a space to consolidate work that's happening across the health system related to issues, not only of aggression, but substance use, suicide, trauma, et cetera. So we've had this body for about 4 years, and it interfaces with our larger quality group at the hospital. And we even consider aggression and behavioral metrics as part of our overall strategy around hacks in our hospital. So that's been really exciting to see. In 2020, in the last 3 years or so, we've been expanding our consult service. We now have a provider and a social worker available 24/7 in our ERs and in our children's hospital. There's a lot of factors that went into this, not just this work, but it was really, really critical for us to see this as an essential component of pediatric medical care delivery. One of the interventions we did, though, is we hired a behavioral health nurse who now goes around on the units and consults to bedside staff. So if respiratory therapy is struggling in delivering a nebulized treatment, the behavioral health nurse will go and develop a plan, model it, talk with the team, figure out strategies. For me as a consult psychiatrist, that may be 2 or 3 hours of my day, kind of working through all that, typing it up. So the behavioral health nurse can do that intensive work and speak nursing language, which has been really great to offload our psychologists and psychiatrists to do some of the other work. We then have been involved in national collaboratives because it's really important when you're doing this work to have that national voice, to keep checking you and making you realize that everything that's maize and blue at the University of Michigan is not, perfect, that we can always be better and do better. And then we really started to take that universal training that I talked about and embed it into the EMR, right? So now we have nurses that are documenting that language in the EMR, checking for how often patients are escalating behavior. The next step to that is to make those into flags and automatic pages so that the EMR documentation then translate into action if patients are demonstrating escalation. Right now, we're working on institutional workplace violence programming, and I'm just starting a process to develop a rapid response team. So hopefully we'll have more information about that. We have an event review process. So if there's any event related to agitation or aggression, we do a root cause analysis. We also are doing scans of the built environment. So I was just on our inpatient psych unit to look at the cameras, the spaces in the hallways, how the doors open up, all those things. And we have a checklist where we go through methodically to look at all of our built environment to see if there's adaptations to that environment to mitigate risk of harm. So you can see the progression here, but it started off with that foundational work with that working group. The goals of our group have not only been to reduce episodes of agitation or aggression, but to think about normalizing what we do. So one of the tricks about this that's been really challenging is how to infuse this into the fabric of what we do without potentially creating a dichotomy where you see certain patients as behavioral patients and then these are our patients, right? We're trying to get away from that, right? These are all of our patients. They're all in our children's hospital. They just have different needs. And making sure families don't perceive that as well. Thinking about intervening upstream. Again, there's that tendency, okay, what are we going to do with restraints, with medications? No, we should be focusing on the non-pharmacologic interventions and how can we make those regular and how can we debrief to ensure what we're doing is actually the right thing. And then I think what's critical and why I presented our system before is knowing your people and knowing your resources is really, really critical to making sure that what you're doing is actually resonating with people, right? You don't want to create interventions that are disruptive to workflow, that are not natural and can't be embedded naturally into the work day environment. So as we went through this, we used lean methodology. And for folks that are not familiar with that, lean is a process of looking at a workflow and eliminating waste in that process to enhance efficiency. So this was really helpful for us because it helped us ground ourselves in what are our processes in current state and what are our workflows and what can we do to actually mitigate challenges in the system rather than just employ solutions that we think are going to work. This was our A3. So this is just our running document of everything we're doing. This was not updated, I think the last update in 2015, but just shows you kind of the desire to keep cataloging all this work so we can reference it as we need to. This was our value stream map. So this was kind of where we were at, the tornadoes and the clouds and all that. Those were challenges. Those were problems in our system. And what we actually did when we looked at our entire workflow from admission to discharge is we had everybody take a sticky tape and go to the board and just put sticky tape on areas that they thought were feasible and actionable. So things that actually we could make a difference and were of high value. And that helped guide our prioritization of the work. And this is how we wanted it to look. We wanted it to look very structured and streamlined. So it was important for us to map this out so that when we were struggling with things, we could go back to our value stream map and our future state map and just iteratively really make sure that we were not deviating in some way from what we intended to do. So we did this for about 1.5 years, and I'll tell you, it's really hard to sit with people who want to act right away and go through that process and really map it out. But it was really important because we identified a lot of problems, right? So these are several of the problem areas that I'm highlighting here, including access to mental health services. Again, I don't think you can provide a service where you don't have all the players and the access that you need. So we had to kind of think about how do we generate that access with limited numbers of mental health professionals available. So just going to quickly go through some of the things that we did. One of the things we did is we had to adopt some type of universal training. So we did have CPI at Michigan before, but felt that that model was not very trauma-informed or psychologically informed. What was nice about this model, and there's a ton of models, I'm not advertising this model at all. This was actually selected by our nursing group because they felt that it provided a much more holistic approach to understanding how to keep the patient calm and safe through understanding dynamics with interaction, language use, using de-escalation strategies, really focused on awareness of the environment, as well as awareness of what we're doing to potentially result in escalation, and then had specific language tied to it, which I'll share here. To be able to do this work, you need to be able to effectively communicate quickly and have standardized communication strategies that allow you to communicate complex ideas quickly, to track and monitor progression. And so we started a process of really looking at our entire communication strategy. So we used that well language to really standardize how we talked about agitation and aggression. And there's a red scale language in there that helps us qualify where a patient's at in their behavior throughout their stay. And that allows us to update the EMR, just like we do with vital signs, Q8 hours, Q12 hours, where the EMR will show that progression. We can map it out and monitor it. We have standard documentation and dot phrases so that when an event occurs, we can gather that information very systematically. One of the most frustrating things is to come in the morning after a major behavioral event, and all you see is patient aggressive, they bit me, gave olanzapine, gave haloperidol, patient asleep. So you have no clue, like, why did this progress? What other things were tried? Was there any other response but outside of the patient being sedated? So we did that. We're doing screening, and then we created language again that normalized that information gathering process. So this is what our red scale language looks like in the EMR. So we have different types or scales for different categories of behavior: agitated, disruptive, destructive, and dangerous. Threat of harm is the idea that somebody is homicidal or suicidal. And so what we do is we have this in the EMR. The nurse can then select different behaviors they're seeing within the category and what interventions they're employing. And you can actually see this in the flow sheet. So, if you're a unit leader, you can go in and say, okay, I see somebody's had 3, shifts of agitated behavior. What's going on? What are we doing? What are we not doing? Do we need to get somebody else involved? And this is what it looks like in the flow sheet, is you'll see it along with some of the other interventions and activities. You'll see the progression, and you can take this and create a Tableau dashboard or another dashboard. You can, develop reports that go out. You can even tie it to paging processes. So if you want certain people to present to the bedside, our behavioral health RN consultant goes in every morning, looks at patients that are screening positive consecutively on higher risk behaviors, dangerous, destructive behaviors. She then goes to our safety huddle and presents this to the health system. This is our standardized template for documentation of behaviors with drop downs and some areas for free text. So in terms of screening, We looked at a variety of screening tools. There are some, but there's none that's been validated in a pediatric medical setting, unfortunately. Hopefully in the next few years, there will be. What we did is we actually developed our own based on an amalgam of different screening tools, and we actually piloted it. So this is what it looks like in our EMR. We looked at patients 5 to 21, and we looked at 2 years of data, both in the hospital and in the ER. We had 32,000 encounters, most of them being in the ER, with 8% screening positive, meaning having a positive screen on our screener for agitation or aggression. We looked at restraint use, security calls to the bedside, the combination of both, as well as patient-attendant presentation. We did not look at PRN medication because it was very hard to assess whether or not PRN medication was actually influencing what we intended to look at. So that we left that off. What we did find is that the most associated factor when we looked at all the screening metrics with an anticipated restraint or security call to the bedside was a history of violent behavior or anticipating. So if the family came in and anticipated violence, that was highly predictive. And these were our stats. So the odds ratio is really high. So this population, if you see a positive screen for history of aggression or anticipation of aggression, the likelihood that there is going to be some type of issue is actually quite high, with a very high negative predictive value, meaning that if you screen negative, the likelihood you're going to need any significant resource is very, very low. So what this does, it allows us to mobilize specific resources to high-risk populations and start a process for these youth. In terms of family engagement, we created a helpful tips for my child document where you can document what triggers, what comfort strategies, what medications there's been a good experience with or maybe not a good experience with, as well as important contacts. And on the back of this form, we described what are the potential escalation points for the patient, what language does the family use to describe that escalation. And we paired that with what we do. This looks very similar to the asthma action plan that a lot of us use in pediatrics, but it's the idea of really stratifying this. Now what we do is we use the same model and we actually apply the well language that I described before to these different zones so that we can categorize that. And what this looks like is each area has some strategies you can employ, some communication efforts, environmental efforts, as well as who you want to engage in the process. We've also developed algorithms in a workplace violence policy that we've developed to identify who to bring into the care and how to escalate care, how to document. We've also created other guidance on some standardized strategies to assess and intervene in different cases. And then pharmacologically, we were part of a national study called the Beta Pediatric Consensus Guidelines to look at standardizing strategies in emergency settings for youth with agitation or aggression. So much of what I said, I think earlier, it comes out in these guidelines that assessment is really critical to identify the etiologies contributing to agitation, asking why now and why here, observing what's going on, even if it's brief, can be helpful in terms of presentation, understanding what may be driving the presentation of agitation, getting that collateral, making sure you do a brief chart review, understanding previous response to interventions, as well as engaging the family and understanding what helps the child and what may be driving that agitation. Some principles identified in these guidelines, it can't be said enough, using non-pharmacologic de-escalation in concert with medications. You just don't move to medications and stop that work. The intent is to calm. You don't want to just sedate. Now, there are situations where people are so dysregulated, so aggressive. We know this in the ER, we know this in the ICU, that people just need to be safe. And sometimes that happens, but that's not the goal, right? Because if you sedate somebody, you can't assess them, right? So you may go hours before the patient's awake and alert where you can engage them. If you can get them calm enough where you can continue assessment it's safe for the patient. It's better for us to continue that process. Avoiding polypharmacy, avoiding rapid switching of medications, which often can occur. And then considering a half dose or an extra dose is something that's already worked. So many times we want to do what's comfortable for us, right? So I use ziprasidone, I use olanzapine, I use haloperidol, I'm just going to give that, or lorazepam. Well, maybe the patient does really well with their stimulant, or maybe they're on a medication like aripiprazole that, works really well for them. Maybe give them their home med if it's due, or if it's close to being due, or maybe give them an extra dose of that medication that's really working rather than giving them something new. Thinking about those medication factors and patient-related factors that may be contributing and thinking critically about that, not as a one-size-fits-all approach. And then what is our training and experience with our staff and teams in terms of delivering this? So in this paper, we didn't want to be overly prescriptive. It's a guide, right? Because we have to use our judgment in each situation given the heterogeneity of this population, but providing guidance on what are appropriate doses, timing of effect, max doses, potential side effects to look for, and then created an algorithm. So what we thought of is that these presentations often fall in different buckets, delirium being one, or an organic factor, substance intoxication or withdrawal, developmental factors, and then primary psychiatric issues. The fifth category is very common, which is a mixed etiology or really unclear. And these things happen very rapidly. So we as a consensus body determined that in those situations, looking at the severity of presentation should drive medication management because it may be very hard to really identify an etiology that you can really address. So we've adapted that at the University of Michigan and have employed this model here. Very similar, but again, non-prescriptive. So we're empowering people with information, giving them a narrowed set of medications they can become very comfortable with. And this is not to supplant a more expert kind of review of the situation, but in those moments where you're trying to think, what do I need to give this patient to help them calm? Here are some strategies and here's the information. But by the way, don't forget about pain, don't forget about sleep deprivation, et cetera. Out of the interest of time, I'm just going to wrap up with this last slide here, just to highlight some of the expanded access we've been doing. So I talked about the behavioral health RN data. So what we were recognizing as we were expanding our psychiatry and psychology service is our bedside staff did not feel attended to and heard. And if anybody knows, if you want to make the family happy, you want to make the care team happy, make sure the nurse is happy. If the nurse is happy and supported and able to do what they need to do, things go really well. And our nurses are really great at being those frontline communicators and supports. We did not have the time or bandwidth to do this. And so we came up with this idea, actually was an idea that came out of Boston Children's, to have a behavioral health nurse do this intensive support and work. What was great about it is we were educating the bedside staff, and this included PT, OT, the techs at the bedside, the attendants, et cetera. And this individual now has done, this is actually older data, but up 256 visits and has really seen a variety of different patients across the spectrum. A lot of her work has been around agitation, aggression, but interestingly, our eating disorder population has been another popular reason to engage her for bedside eating support. She also helps with documentation. So when people say, oh, what am I supposed to document when we do a restraint? What am I supposed to document if there's a behavior? She'll walk through all of that with folks, remind them. She goes to the system-wide safety huddles. She does a lot of education at the bedside. And this has been tremendously helpful because as people are employing those foundational skills, she's also supporting higher level skill development and providing access when those foundational skills are not sufficient to support patients. So I will stop there out of the interest of time and welcome any questions.